We will continue with Part 2 of Module 1 of the Alterations of the Endocrine System. The posterior pituitary gland secretes vasopressin, also known as antidiuretic hormone or ADH. Posterior problems result in fluid and electrolyte imbalances. Disorders of the posterior pituitary gland are related to a deficiency or excess of the hormone and usually occur independently from anterior pituitary problems. Diabetes insipidus occurs with ADH deficiency, and the syndrome of inappropriate antidiuretic hormone, also known as SIADH, occurs with ADH excess. Okay, let's first discuss diabetes insipidus, also referred to as an ADH deficiency. Water metabolism problem is caused by an ADH deficiency, either a decrease in the ADH synthesis or the inability of the kidneys to respond to the ADH. So basically, classifications are nephrogenic, primary, secondary, or drug-related. Okay, so let's discuss the deficient hormone and the clinical manifestations. So discussing the vasopressin, which is the antidiuretic hormone, will greatly increase urine output. Low urine specific gravity. There will be hypovolemia, hypotension, and or dehydration. There will be an increase in plasma osmolarity. There will be an increase in thirst. And then the output does not decrease when the fluid intake decreases. In the cardiovascular system, the clinical manifestations will be hypotension, a decreased pulse pressure, tachycardia, peripheral pulses are weak and easily blocked, and then there is hemoconcentration such as an increase in hemoglobin, an increase in hematocrit, and an increase in the BUN. The kidney and urinary manifestations is an increase in urine output. There will be a dilute low specific gravity and hypoosmolar. The skin will result in poor turgor and dry mucous membranes. Neurologically, there will be an increase in thirst sensation, irritability, decreased cognition, hypothermia, lethargy and or coma, and ataxia. You will assess for an increase in urine, excessive thirst, signs and symptoms of dehydration, and record the 24-hour intake and output. Treatment will include early detection of dehydration and maintenance of adequate hydration. They will need lifelong vasopressin therapy with the permanent condition. You want to teach patients to weigh themselves daily to identify any weight gain. Drug therapy will include desmopressin, vasopressin, and chlorpropamide. Okay, so let's discuss the posterior pituitary hyperfunction. We have SIADH, which is ADH excess. Vasopressin is secreted even when plasma osmolarity is low or normal. The feedback mechanisms do not function properly. Water is retained and results in hyponatremia. There is a decreased serum sodium level. Some malignancies responsible for posterior pituitary hyperfunction are small cell lung cancer, pancreatic, duodenal, and GU carcinomas, thymoma, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. Central nervous system disorders that can be responsible for posterior pituitary hyperfunction are trauma, infection, primary or metastatic tumors, strokes, porphyria, or system lupus erythematosus. Pulmonary disorders responsible for posterior pituitary hyperfunction are viral and bacterial pneumonia, lung abscesses, active tuberculosis, a pneumothorax, chronic lung disease, mycosis, and positive pressure ventilation. Drugs that can be responsible for posterior pituitary hyperfunction are exogenous ADH, chlorpropamide, vincristine, cyclophosphamide, carbamazepine, opioids, tricyclic antidepressants, and general anesthetics. So clinical manifestations and treatment can include a clinical manifestation of recent head trauma, cerebral vascular disease, TB or other pulmonary disease, cancer, all past and current drug use, and there will be a decrease in serum sodium levels. Treatment will include restricting fluid intake, promoting water excretion, provide sodium replacement, provide a safe environment, and perform a neurological assessment. Drug therapy will include tolvaptan, conivaptan, diuretics, antibiotics, and or a hypertonic saline. Okay, we're going to discuss the adrenal gland. The adrenal gland produces and secretes hormones that influence homeostasis and are life-sustaining. Hypofunction of the adrenal glands is referred to as Addison's disease or Addisonian crisis. Hyperfunction of the adrenal glands is referred as Cushing's disease, Hyperaldosteronism, or Pheochromocytoma. First, we will discuss the hypofunction of the adrenal gland disorders. Okay, let's first discuss Addison's disease. There is adrenocorticosteroids that may decrease from the inadequate secretion of ACTH. There is a dysfunction of the hypothalamic pituitary control mechanism. There may be a direct dysfunction of the adrenal tissue. We must review Addisonian crisis versus Addison's disease. Primary causes of Addison's disease are idiopathic, tuberculosis, metastatic cancer, fungal lesions, AIDS, hemorrhage, gram-negative sepsis, adrenalectomy, abdominal radiation therapy, drugs and/or toxins. Secondary causes can be sudden cessation of long-term high-dose glucocorticoid therapy, pituitary tumors, postpartum pituitary necrosis, hypophycectomy, high-dose pituitary radiation, and/or high-dose whole brain radiation. Addison's crisis is a life-threatening event. There is a need for cortisol and aldosterone, which is greater than the available supply. It usually occurs in a response to a stressful event. The emergency care indicated is hormone replacement, hyperkalemia management, and hypoglycemia management. The assessment includes a thorough history and a complete physical assessment. Clinical manifestations include weakness, fatigue, joint and muscle pain, anorexia, nausea, vomiting, abdominal pain, bowel changes, weight loss, salt craving. Then there's vitiligo and hyperpigmentation. They may also experience anemia, hypotension, hyponatremia, hyperkalemia, or hypercalcemia. They may be lethargic, depressed, confused, psychotic, or even fearful. Diagnostics include checking levels of the sodium, potassium, glucose, calcium, bicarb, BUN, and cortisol. Imaging may be required, such as X-rays of the skull, a CT, an MRI, or an arteriography. Drug therapy treatment includes cortisone, hydrocortisone, prednisone, or fludrocortisone. Okay, now we are going to discuss the hyperfunction of the adrenal glands. Endogenous secretion is known as Cushing's disease. It is a bilateral adrenal hyperplasia. It can be a result of pituitary adenoma, which increases ACTH production. There could be malignancies, carcinomas of the lung, GI tract, or pancreas, or it could be the adrenal adenomas or carcinomas. Then there is exogenous administration, referred to as Cushing syndrome. This is a result of therapeutic use of ACTH or glucocorticoids, most commonly used for treatment of asthma, autoimmune disorders, organ transplantation, cancer chemotherapy, allergic responses, and/or chronic fibrosis. Basically, hypersecretion by the adrenal cortex results in Cushing syndrome and/or disease, hypercortisolism, or excessive androgen production. The assessment for hyperfunction include a thorough history and a physical exam. The clinical manifestations a patient can experience are a moon face, a buffalo hump, truncal obesity, hypertension, edema, bruising, atrophy or fractures, thinning or striae of the skin or an increased pigmentation. They may have infections or a decrease in inflammatory response. They may appear to be irritable or have mood swings. Laboratory diagnostics will include blood tests, urine tests, salivary tests, or cortisol level tests. Other diagnostics are X-rays, a CT, a MRI, or an arteriography. Treatment includes patient safety, drug therapy, monitoring eyes and nose, weight monitoring, providing radiation therapy, or there may even be surgical management. And then for post-operative care, you want to, of course, you're going to have the replacement therapy, but you're also going to monitor for shock, vital sign, eyes and nose, daily weights, and electrolyte levels. Hyperaldosteronism is increased secretion of aldosterone, which results in mineralocorticoid excess. Primary, referred as Conn syndrome, is a result of excessive secretion of aldosterone from one or both adrenal glands and usually caused by a benign adrenal adenoma. Secondary is a result of excessive secretion of aldosterone that is caused by high levels of angiotensin II that are stimulated by high plasma renin levels. Clinical manifestations include hypokalemia, increased blood pressure, headache, fatigue, muscle weakness, nocturia, loss of stamina, polydipsia, polyuria, and paresthesias. Treatment can include adrenalectomy or then drug therapy when surgery cannot be performed. Okay, let's discuss pheochromocytoma. This is a catecholamine-producing tumors that arise in the adrenal medulla. These tumors produce, store, release epinephrine and norepinephrine, which mimics the action of the sympathetic division of the autonomic nervous system. The main cause is unknown, but some occurrences have been linked with inherited disorders. These type of tumors are rare and most often found in women, and commonly appears between the ages of 40 to 60. Clinical manifestations include intermittent hypertension, headache, palpitations, profuse diaphoresis, flushing, apprehension like the impending doom feeling, chest or abdominal pain, nausea and/or vomiting, and then hypertensive crisis. Treatment is surgical management. This is the removal of a tumor. You want to monitor for shock. You want to monitor vital signs, the intake and output, daily weights, and electrolyte levels. This concludes the lesson of care of patient with the pituitary and adrenal gland problems. If you have any questions that are related to this lesson content, notify the instructor.